Okay, so we've spoken a bit about this already, the mechanics of breathing or the mechanics of ventilation. So the lung needs to be elastic in order for it to expand, but even more importantly, in order for it to recoil. So the lung is like a rubber band. It can stretch open, and when let go, or when the chest wall, intercostal muscles, and diaphragm stops contracting, it can recoil back to normal. Okay, lung compliance is telling us how easy is it to expand and stretch with each breath. So if you have a very non-compliant lung, it means that it's really hard to take a breath. Okay, and there are conditions such as pulmonary fibrosis where you have very poor lung compliance, and it's very hard to take a breath in to expand your lungs, right? So let me give you another example. Someone who is morbidly obese, well, they're going to have reduced chest wall compliance, meaning the intercostal muscles and the diaphragm are going to have to contract really hard to open up this chest wall because there's a lot of weight associated with it. Okay, so chest wall compliance is the ability of the chest wall to expand. And if there's a lot of tissue on it from, say, being morbidly obese, then you have a low chest wall compliance. Okay, so normally our chest wall and our lungs are very compliant. Okay, it's easy to take an air. It's easy to take a breath in. Now imagine putting a belt around your chest and tightening it. Well, you've just increased chest wall compliance, and that's what, say, morbid obesity can do. It's causing it's causing reduced chest wall compliance. Okay, and the same thing can happen with the lung in lung diseases such as pulmonary fibrosis, where it's very hard to stretch the lungs out, so you have reduced lung compliance. Okay, what about an infant that's born prematurely and they have low surfactant? Well, they're going to have a low lung compliance, right? They're going to have a really hard time expanding their lungs. Okay, so their chest wall is fine, but they have non-compliant lungs to expand. Resistance to airflow is purely determined by the airways, so the trachea and the bronchial tubes, and in particular the bronchial tubes, because that's where you typically have conditions such as COPD and asthma that cause mucus secretion and bronchoconstriction in the smaller bronchial tubes. And the smaller the diameter of the airways, the higher the resistance to airflow in those tubules. Okay, so really any alterations can force someone to have to work much harder to breathe. So if you don't have elastic lungs, okay, they're not going to recoil back to normal. Okay, that's someone with COPD. They've lost the elasticity of their lungs. So the lungs don't recoil back to normal and they stay inflated, and that's why they have a barrel chest. Lung compliance, okay, that's the ability to stretch the lungs. And if your lungs aren't compliant, such as in pulmonary fibrosis, it's going to be hard to take a breath in. Chest wall compliance, if you have lots of tissue, obesity, something that's impeding your chest wall from expanding, that is low chest wall compliance. Okay? Okay, so the concept of work breathing is important because we're always looking at patients to determine how hard are you having to work to breathe. And usually you get used to seeing that, and just the visual gives you lots of information. So if we're watching someone hanging onto a table and unable to talk and gasping for air, they're working really hard to breathe. We're concerned about them. They might need to be intubated because they can't breathe for themselves. Okay, so the work of breathing is often a very visual uh, thing to experience. And you use a lot of energy if you have certain diseases to inhale and exhale. Okay? Usually the work of breathing of someone who's healthy is very easy. It's easy to breathe in, easy to breathe out. So what determines the work of breathing? So, well, the work of breathing is increased by anything that narrows the airways. So, for example, obstruction of the airways, mucus in the airways, such as in COPD or asthma, a tumor in the airway, any kind of infection, such as bronchitis in the airway, can narrow the airways. What about anything that reduces lung compliance, the ability to expand? Well, patients are going to breathe with more difficulty if they have stiff lungs. And who could have a stiff lung? Well, what about someone with pulmonary edema? So someone with pulmonary edema has a lot of fluid in their lungs, all around their alveoli, so they will have non-compliant lungs. And anything that reduces chest wall expansion. So say, for example, you broke your ribs and you're unable to expand your chest wall due to the pain. That's going to make you breathe very shallowly, and you'll have decreased chest wall expansion. Okay, so rib fractures, morbid obesity, neuromuscular diseases such as myasthenia gravis or Guillain-Barré can reduce chest wall expansion and increase the work of breathing because they can't take deep breaths anymore. Okay, so look at those three on the left and see how they interact, and all of them can increase the work of breathing if they're not functioning normally. Okay, so let's just talk about some preventative measures for respiratory illnesses. And in fact, this really applies for any infectious diseases. So frequent hand washing, right? So between patients, it's very important to wash your hands so you don't spread an infection from one person to yourself or to another patient. Avoiding close contact. So if at all possible, it isn't always possible, but to avoid close contact is important because coughs are often spread in droplets, and if you're not very close to someone who's infectious, the droplets aren't going to get to you. Okay, you're not going to inhale the droplets. Covering up a cough, very important to stop the droplets from getting into the air in the first place. Avoiding sharing personal items is important, okay? And also maintaining a clean environment. So whether it's in a clinic or on an inpatient floor or the emergency room, very important to keep a clean environment because it's very easy to spread infectious diseases from one room or one patient to a healthcare provider or to other patients. Okay, so let's talk about some conditions of the nose. Okay, let's look at this of the slide of the nose here on the right, this image. So the nose actually goes straight backwards. Okay, so when we do a swab of someone's nose, we don't point it upwards. If you point a swab upwards, it's actually going towards the brain, right? So we go backwards with swabs. And you can see that the nose has little sinus pores or ostia, and that's where the sinuses drain back into the nose. So you can have the maxillary sinus, which is in your cheek, that'll drain back into the nose, and there's other sinuses that drain back to the nasal cavity. And you can see here that the brain is very close to the upper inside of your nose, right? There's actually a plate at the top of your nose called the cribriform plate. And it's very thin and delicate. It's not hard to fracture that if you have, say, a facial fracture. Okay, so we're pretty careful about putting swabs that are directed upwards, or say a nasogastric tube. We point them straight back, not upwards. Okay. All right. So nasal polyps are non-cancerous growths that grow in the nose, right? And they're often caused by chronic allergies or inflammation in the nose, resulting in these polyps. And often we'll put patients on nasal steroids to shrink the polyps and also to control the inflammation and allergies. But if the polyps are large, they need to be removed with surgery. Okay. Epistaxis is a nosebleed. And typically with a nosebleed, especially a nosebleed that's close to the nostrils, it's easily stopped by just applying pressure to the soft part of the nose. Okay, so direct pressure on the nares, not the bony part of the nose, but the soft tissue next to the nostrils, putting pressure there for 10 to 15 minutes. Usually stops most nosebleeds. What about a nasal injury or a facial injury for that matter? Well, you can have a nasal fracture, okay, that's possible, or a skull fracture of that cribriform plate I was talking about, which is that horizontal plate at the top of the nose in this image. And when you fracture the cribriform plate, one of the signs that you fractured it is that you're leaking cerebrospinal fluid out of your nose. So if someone comes in and they've been, say, punched in the face and they have facial fractures and they're dripping clear fluid out of their nose, that can be an indication that they're actually dripping cerebrospinal fluid out through their nose through the cribriform plate. Okay? And lastly, at the bottom there, the term rhinitis. Rhinitis is just inflammation of the nose, and it's typically caused either by allergies, so allergic rhinitis, or by a viral infection that gives you a stuffy, runny nose. Okay. Okay, so let's talk about bronchitis. So acute bronchitis is typically just caused by a viral infection. And patients cough, they have mucus production, they might be a bit short of breath because they have some wheezing associated with it. They might be breathing a bit faster because of the wheezing. And if the bronchitis is very severe, they may even have accessory muscle use. And often there's a fever with bronchitis since it's a viral infection. Okay? Most patients that are healthy with acute bronchitis don't need any antibiotics. They may need an inhaler if they're very wheezy to help bronchodilate the lungs or the bronchial tubes. Now, chronic bronchitis is someone who has COPD, right? So COPD is a combination of chronic bronchitis, so a chronic cough associated with mucus production, and emphysema, right? So COPD is a combination of chronic bronchitis and emphysema. And emphysema is the destruction of alveolar tissue. COPD patients that come in with a flare-up, yes, they have bronchitis as well, possibly. We treat them with antibiotics because they're at higher risk for having a bacterial infection as the cause of their COPD flare-up. Okay? So the image on the right is just showing you the mucus that gets produced during bronchitis. Again, most of us with acute bronchitis that are healthy, it resolves on its own without any antibiotics at all. Okay, what's pneumonia? So pneumonia is an acute lung infection, and it's a very common cause of death from an infectious disease, right? And lung infections can be caused by bacteria or viruses, or very rarely fungal infections if you're immunosuppressed. So the vast majority are bacterial or viral. We always treat pneumonias with antibiotics because we just can't distinguish between a viral or a bacterial pneumonia. They really behave the same way, and without getting a piece of the lung tissue, we can't determine whether it's bacterial or viral, and we don't normally biopsy someone's lung for a pneumonia, so we treat them with antibiotics. What are the risk factors for getting a pneumonia? Well, if you're immunosuppressed, you're definitely at risk for getting any kind of infection, including pneumonia. If you have weak lungs, such as in COPD, you're more at risk for getting a pneumonia. If you're lying in bed, not getting up very much because you have an illness that's put you in bed for days to weeks, you're definitely at risk for pneumonia because you're not taking good breaths. Aspiration is usually in someone who has some kind of a neurological condition, such as a stroke, and they have difficulty swallowing properly. And some of the saliva or food or even gastric contents that they vomit up gets into their lungs. Okay? And that's a real problem. That's called aspiration pneumonia. Okay? So really anyone who has an underlying lung condition is at higher risk of getting a pneumonia. What are the symptoms of pneumonia? Well, typically you're short of breath, you have a fever, you're coughing a lot with mucus production, you're weak, you're potentially confused because your oxygen levels in your blood might be reduced, you may be hypoxemic. When we listen to your lungs over the area with pneumonia, you might have crackles or crepitations, okay? And depending on how ill someone is with their pneumonia and how short of breath they are, and of course how hypoxemic they are, will determine whether they stay in hospital or whether they go home with antibiotics. So someone who's very ill with pneumonia will be admitted to hospital for IV antibiotics. Someone who has normal vital signs, so a normal blood pressure, a normal heart rate, their oxygen saturation is good, and they don't have an increased work of breathing, they can likely go home with a pneumonia and take oral antibiotics. Okay, so let's get into more detail about chronic obstructive pulmonary disease, COPD. And COPD is really a combination of two underlying conditions. So there's emphysema, which is damage and destruction to the alveoli. Okay, so that's where gas exchange occurs. So there's going to be problems with gas exchange due to damage to the alveoli. And the other part of COPD is chronic bronchitis. And that is ongoing secretion and production of mucus and damage to the bronchial tubes, which results in a chronic cough. So a typical patient with COPD has a combination of both of these. It would be rare for someone just to have chronic bronchitis or just emphysema. It's some kind of a combination of both. And often they have chronic shortness of breath, chronic cough, chronic mucus production, and often they are hypoxemic because the alveoli are also destroyed. So when we're talking about patients with chronic respiratory conditions, such as chronic obstructive pulmonary disease, cystic fibrosis, asthmatics, there's vaccines that are recommended for these patients to receive, right? So the influenza vaccine, which is annual, is recommended. A Tdap, because there's diphtheria vaccine, and pertussis, which is whooping cough, which can really flare up COPD. A pneumococcal vaccine, which protects against certain strains of pneumococcal pneumonia, and as well a shingles vaccine. Okay, shingles is typically a condition of the skin where you develop a blistering rash, but you can rarely get the virus damaging the lungs and leading to a pneumonia. Okay, but in general, I would think of shingles as a blistering skin rash, right? And it's from having had chickenpox in the past. Okay, so what about vaccines that are recommended for healthcare workers? Well, typically that would be your annual influenza vaccine and your Tdap, again for the diphtheria and the pertussis. So COPD is a very common condition. Okay, so it's one of the leading causes of death in the United States. And really, it's a chronic inflammatory condition to having inhaled noxious particles and gases. And by far the most common risk factor for COPD is cigarette smoking. Now, pollution in many cities can be a contributing factor. Being exposed to chemicals, say at your occupation, can be a risk factor. But in general, COPD, for the most part, is directly linked to cigarette smoking. Now, there is a condition which is inherited, which is called alpha-1 antitrypsin deficiency. And this is a condition where you're deficient in this enzyme, and it results in damage to the elastic tissue of the lungs and destruction of the alveoli. And that leads to COPD. So, for example, if someone presented with COPD and they were a non-smoker, there was really no explanation for why they had COPD, they can be tested for alpha-1 antitrypsin deficiency. So what are the common symptoms of anybody with COPD? So typically they're dyspneic, they get short of breath on exertion as well. They have a chronic cough with chronic sputum production. They often have a barrel chest, because remember, the lungs don't recoil back to their normal size, so they stay hyperinflated. They're often hypoxemic in their blood. They can be cyanotic, meaning that they're hypoxemia is so significant that they're now presenting with cyanosis of their digits, or maybe around their lips. They can be cyanotic. And they're often polycythemic, meaning they have an elevated hemoglobin level. And that is due to the chronic hypoxia. So what does the kidney do when it detects low levels of oxygen? It produces erythropoietin, which stimulates more hemoglobin production to try and compensate for the low oxygen levels in the blood. And they become polycythemic, so elevated hemoglobin levels. In fact, smokers in general, even if they don't have COPD, tend to have higher hemoglobin levels because, again, the body is detecting that there's lower levels of oxygen in the bloodstream. There's actually higher levels of carbon monoxide from the smoke, and it produces erythropoietin, resulting in polycythemia. They can become or develop respiratory acidosis, right? So if they're unable to clear the CO2 out of their bloodstream because damage to the alveoli has been significant, they'll retain CO2, and that will turn into H+, resulting in a respiratory acidosis. When they're very short of breath, say they have a COPD flare-up, they breathe with pursed lips. So I think this one would be a good one to look up, pursed lip breathing, to see an image of it. But basically what they're doing when they're pursing their lips and making their lips close together is that they're creating some back pressure into the lungs. And what that causes is keeping the alveoli open, and it tends to help them breathe better. Okay, so it's called pursed lip breathing. And the treatment for COPD is bronchodilators, steroid inhalers are common, and sometimes when they have a COPD flare-up, they require oral steroids such as prednisone and antibiotics to treat the COPD flare-up. And when I use the term COPD flare-up, I mean someone who has COPD already and has now presented with increased sputum production, increased coughing, increased shortness of breath, and they likely have an underlying infection that's causing all this. Okay. Now, mucolytics can be used. So if someone has really severe COPD and they're in hospital, we could give them inhaled acetylcysteine to try and break up some of the mucus. That's not used very frequently, but it is an option as well for COPD. Okay, so let's talk about COPD and oxygen. So there's many people at home actually that require home oxygen for their COPD because they're chronically hypoxemic, and their level of hypoxia is too low. So they require home oxygen, usually with nasal cannula. Okay, so let's say someone comes to the hospital with COPD and we need to apply some oxygen because they're very short of breath and their oxygen levels are reduced. So let's say they have an O2 saturation of 80%. So a patient with COPD often has elevated levels of carbon dioxide in their bloodstream because they're unable to clear the carbon dioxide due to alveolar damage. So what's making them continue to have a respiratory drive is their low levels of oxygen, their hypoxia, which is stimulating the brainstem to force them to breathe, right? So if we give them a lot of oxygen, say we give them high flow oxygen and try and get their O2 saturation to very high levels, say 98 or 99%, that's going to turn off the hypoxic drive to the brainstem, and they're going to breathe more slowly. They're going to take less deeper breaths. But what's that going to result in? It's going to cause higher levels of COPD, of carbon dioxide. And as the carbon dioxide starts to build and build and build, because you gave them so much oxygen and tried to correct their hypoxemia into a very normal range, such as high 90s, then the CO2 is going to increase, and they're going to develop something called CO2 narcosis, because high levels of CO2 starts to make you lethargic, decreased level of consciousness, very, very tired. So we're careful about how we give a COPDer oxygen. We don't crank it up to 100% high flow oxygen because we know it's going to turn off their hypoxic drive and result in a buildup of CO2 in their bloodstream, causing them to go into CO2 narcosis, be very sedated. Sometimes we can't even wake up these patients, and that's going to result in them having to be intubated. So the better option is to start them with lower flows of oxygen and get them to a level of oxygen in their bloodstream that's safe, but not very high. Okay, so let's say someone with COPD typically lives at an O2 saturation of 88%. Well, we don't want to get them to 99%. We just want to try and return them to their normal range, okay? Because if we force them to have high flow oxygen, it's going to turn off their respiratory drive, leading to CO2 narcosis.